10 years later, we are discussing something similar to that topic again. And maybe I'm asked to come here to show some accountability for what has happened since then. And I would like to make some remarks that would hopefully stimulate some discussion as to how we can get forward. In doing that, I'll show a few slides to take us on. Somebody sent me a statement on Facebook the other day that I found very interesting, which says health does not come from medicine. Most of the time, it comes from peace of mind. It comes from peace in the heart, peace of soul. It comes from laughter and love. And so there you have all the bottlenecks to health systems and communities. And so if you don't have peace of the soul and love as part of how we set up health systems, we shall have some challenges and bottlenecks. And so let me start with a brief overview of some of the challenges and issues affecting our health in the region. There has been a lot of progress, somewhat. We started from a relatively low base, but our life expectancy, adult mortality, under 5 mortality, general morbidity and mortality declines in HIV, malaria, and TB with the support of the global health initiatives were quite significant improvements. Again, we've also, as a region, quite significantly increased the amount of money we spend on health. Indeed, we have not reached the Abuja target, but we've moved from a very low base of 3.7% to about 11%. And so even though we've been challenged quite a lot around development issues and around health statistics, we did have these improvements. But the issue has been these improvements have not been at all homogeneous across our conflict. If you take the total health expenditure, for example, there are still areas where it's as low as 24. That's total, government, out of pocket, anything you can mention, per capita, in 2013, not long ago. And so, in some of the countries also that have spent very high amounts of money, the results have not been commensurate with the amount of money that they spent. And I think we are all aware of the fact that very few of our countries have achieved the Millennium Development Goals in health. But then there are still other game changers, other challenges, what I call the 5 transitions that our continent is going through. My friend calls it the 5 horsemen of the apocalypse, if we do not do much about them. One is we have a demographic change happening in our region. We still huge populations of youth, but also of people like us, the elderly, who are increasing in numbers as well. What that means is that we still have a burden of communicable diseases as well as non-communicable diseases. But in addition to this is the changes in economics and GDP in our countries, an increasing middle class, and rapidly shifting set of population to be about 50% of our population in the continent would be urbanized quite soon. We already are over 45% in that regard. And so this means quite a shift in what to expect around health. Of course, there are the social, cultural traditions that still exist, as some of you who have worked with Ebola would know, very much challenged our so-called scientific efforts in order to address this. And of course, because of Ebola, we now know that we have to pay particular attention to our health security risks. There's climate and environmental changes. There's a lot of conflict in many parts of our region. And in addition, we have increasing antimicrobial resistance and also quite a number of substandard fake and counterfeit medicines flowing in our region. And all these constitute a set of challenges that are rising even beyond what we deal with already. And so what are the bottlenecks to health systems and communities, and what are they, and why do we have them? From my previous statement, I think part of the challenge is there's a bewildering array of priorities that we need to deal with, of needs, of demands, of changing situations. We have urban communities, we have rural ones, we have ethnic ones, we have pastoral ones, we have those of different cultures and so on, and having the same standard type of the health workforce, for example, that is global, that we want to work with everybody might not make us reach the kind of results that we want. Finally, not finally, the structure of our service delivery is the other challenge that we have. We need to have more innovative services in order to reflect the kind of communities and the kind of societies that we have. We need to, even within a country, the essential package of services that we deliver may need to differ from one part of the country to the other in order to be able to reflect what the needs are in different parts. My senior colleague, Professor Maswa, who will be speaking soon, often says that health is made in communities and in the home. It's only repaired by the health services. But we need to build systems that support the making of health in the home, as well as establishing services that will repair them and sustain health when things go wrong. The other thing that I think is the challenge is around governance, leadership, and stewardship failures in our region. And this is not only from the health sector, but sometimes from a whole set of other sectors as well. It is also from communities themselves. Sometimes we get the impression that communities are holy, they are saintly, and have no contribution to some of the challenges that we feel in trying to deliver health. And I think we need to recognize that the complexity of communities and the challenges they prefer is also due to some of the leadership issues that have arisen from those communities themselves. But a lot has been said about our leadership and governance challenges. There's often quite little accountability for results, and I've also felt, working as a Minister of Health official several years ago, that sometimes the focus of our accountability is more to the external aid providers than to our communities. And so the kind of responsiveness that we need to engage with in order to provide the results do not happen. I'm not saying we shouldn't be accountable to donors, but health sectors should be structured in such a way that the dual accountability is strengthened, and our partners to ensure that we should not forget the poor and their rights and their responsibilities. And so, how can communities and health systems interact better? If you can read what's at the bottom there, it says, never ever think outside the box. And I'm not against thinking outside the box. But I think even within the box, we have quite a large number of solutions and ways of working that would work, that we have not tried. And so whilst it's important to think outside the box, sometimes it's also important to look back in the box and try and apply what needs to be done so that we get the results that we want out of our health systems. And so I'd like to leave that slide now, not to discourage you from thinking outside the box, but to say, let's look within ourselves, let's look at what we have. We have quite a large number of research carried out, studies carried out about our communities. In one, I was talking to the mobile companies in Ghana, for example, and they tell me they've had over 40 pilots of mobile health applications in that country alone, in different settings. Not one has been scaled up. And so we do many things, we learn all the lessons, but we have great difficulty applying this in a way that results in effective health. And so how can communities and the health systems interact better? I would like to propose that first we need to create good facilitators of the interaction between communities and health systems. Critical to that, I feel, is good governance, management, and accountability. We all need to put our heads together to see how we can improve that. That is a fundamental issue that undermines the way health systems can produce results. I think we should look at all health policies, strategies, plans, actions, services, and see whether they pass a community-friendly test. And with that, we need to develop this, and that would encourage both communities and the health sector to begin to see what they should expect out of our services. The second facilitator, I think, to that is we need to professionalize the management of health in Africa. We need a cadre of motivated, capacitated managers at all levels of the health systems in order to encourage responsibility to communities and accountability for health. The second area is about sustainability. That we often try things out and then we come back with nothing in hand. Sustainability also comes from the quality of governance and accountability, particularly at the decentralized levels that have the most interaction with the population. It is also where the intersectoral collaboration that is critical for ensuring that health gains results takes place. And we need to encourage that marriage between the health sector and those other sectors that are important for health. We need to establish continuous engagement with communities, not only when we want to give that immunization or to deliver that service. One of the lessons Ebola taught us, I just joined the regional office then, was the fact that we didn't know where to find the anthropologists that we needed to unpack the challenges that created a blockage to communities almost denying their self-preservation because of culture and traditions. And it took quite a while for us to engage with that to begin to get a downward trend in that outbreak. We need to build health workers who are familiar with typical communities in a country and to know their technical skills, but also have the qualitative attributes that would allow them to engage better with communities. Thirdly, I think we need to build the community's capacity and power. We need to evolve them. We need to build the leadership to understand what their rights are, what is the awareness around the health issues affecting their communities. Sometimes we take it for granted that they just can't know anything. And because that knowledge gap is so big between the service providers and the communities, that has challenged an ability for us to work together to get the results that we want. And so one of the things that I feel we should put some more effort at, we keep training health workers over and over and over again, is to invest some effort in getting communities to meet us halfway to creating new systems. The next and final area where I think communities can interact better is closing the knowledge, and I call it power gap, by investing in data, investing in research, investing in evidence. And not only for the technical aspects of the health sector, but also for our communities to understand and know what it is that is happening in their communities. We need to have a shared strategic vision as to how our communities should evolve and grow to become healthy players in our country. And so that is going to be very important. I think each and every country should have at least one excellent research institution that should be able to take us through our work on communities and better support what the health sector does, but also grow communities in a way that they can interact better. For us in the WHO, we have initiated steps to make the implementation of health systems more operational. We've just finished a forum in Windhoek in December, where we developed an actions framework that is to put operational steps in place that every community, every health sector can measure and see how they're progressing towards universal health coverage and the SDGs. But most importantly, to make it clearer how we can measure and monitor our steps towards achieving this. Let me end by saying whatever our difficulties or our setbacks and whatever the challenges we have ahead, we have no choice but make our communities at the forefront of maintaining health and health systems. Thank you very much, moderator.